Good afternoon. Thank you for staying late. I'm Waleed Al-Khyatt, consultant bariatric surgeon from HealthPoint, and I have the pleasure to introduce Prof. Carel Le Roux once again this afternoon to talk us once again. He needs no introduction, but I thought to add a few facts to the biography already mentioned in the small booklet in front of you. He's a top man, top doctor, and he's a sportsman. So as a medical student, he represented South Africa in the World Championship in track and field and came 12th. And represented again South Africa and all Africa competition, championship, and he came first, so won the gold medal. So he's not just a top doctor, he's a top man. He has track record of publication, high impact publication. His work cited more than 20,000 times in high impact journals, and he got an edge index of more than 75. So very impressive academic portfolio as well. It's a pleasure to introduce you, and his talk will be about prioritizing health gain in obesity. Sorry, I was someplace about the sport background. In obesity management with a semaglutide of 2.5 milligram. Enjoy the talk. Thank you, Carl.
Thank you so much. And, it's a bit of history of my misspent youth, but there we are. So thank you so much. I'm going to show you data that you have now seen more than 3 times already today, but we're going to really delve into it. And I think the talk that Dr. Waleed gave now was really excellent because it set us up for this discussion. These are my conflicts of interest, and I think, what we are now seeing with our patients who have cardiovascular disease, for so long we've been asking those patients to eat less and move more. And that is as effective as asking Sisyphus to roll the rock up the hill. And we have never shown that if we ask patients with cardiovascular disease to eat less and move more, that we reduce events. But now we have evidence that we can actually treat the disease of obesity and reduce events as well. And of course, that comes a lot from the SELECT study that Donna Ryan was a lead investigator for. But, you've also seen just the burden that we have with cardiovascular disease. And I must say that I was one of the few people that really did not think that the SELECT study would have been positive. When the SELECT study was presented, I thought that the residual risk is too low, meaning that you as practitioners, when we a fat is strongly an independent risk factor, especially when it comes to HFpEF. And it's difficult for us to measure intra-abdominal fat. Yes, we can do waist circumference. Yes, we can do the waist to height ratio, as we've learned so much in this conference about, but it remains a challenge. And I think this is something that we're going to work more on to actually understand. Now I'm showing you the graveyard of obesity treatments when we try to treat people with cardiovascular disease. And you will be familiar that every time in the past, when we tried to show that if we can have intentional weight loss with medications, we actually either showed neutrality or, in fact, we showed harm. And it was only when the SELECT study came out that you can see the green in the bottom that actually shows that we can actually create a benefit to our patients. And of course, we are now waiting for the plethora of new studies that's coming out. We're waiting for REDEFINE 3, which will show us CagriSema. We also have seen, as has been alluded to before, some of the new tirzepatide data and others that's going to come. And I think this is going to be a paradigm shift because we as obesity internal medicine doctors, general practitioners, general obesity physicians, we've been incredibly enthusiastic, and talking about obesity treatment. But it's only when our colleagues, such as the cardiologists, when they have their megaphones, when they can start talking about the benefits of these treatments, that is when we really have the impact that is required. So working together and certainly working with our cardiology colleagues and showing this data, is changing the narrative. So let's dive in quite deeply into the SELECT study again that you have already seen. 17,000 patients and over a period of time, over 4.5 years. And as you have heard, these patients did not have type 2 diabetes. Because actually, we forget sometimes just how robust our data is when it comes to patients with type 2 diabetes and obesity when we treat them with this class of medication. But let's look at those patients that did not have type 2 diabetes. And of course, I'm going to delve into a little bit more detail now, just to remind you about the nuances and how this is different. So first is that when we look at most of our obesity studies across the world, we predominantly recruit females. But what you see here, 72% of the patients were male. Now, that is not because the doctors were bad doctors and excluded females, from the study. It also reflects our clinical practice. But it does mean that we actually need to delve more and actually get more data also in females, because we understand that very often females with cardiovascular disease is under-recognized and under-treated. So that's an important issue. But we can see that these patients were older. And if we look at what the patients were when we recruited them, 67% had myocardial infarctions only, 17% strokes, and then peripheral arterial disease was only 4%. Again, something that I think we need more data on, because this is actually not only valuable from a vascular point of view, but also from a functionality point of view that we will talk a little bit in more detail. Now, if we look at the distribution of the body mass index, of our patients, we will see that that also looks different to most of our obesity studies. Now, when we're actually looking at the average BMI of our obesity studies, we're looking at a BMI of about 38. And we have far more patients with BMIs above 35, above 40, or above 45, such as those treated by our colleagues, who do bariatric surgery. So this study actually had a very large number of patients, 28% of patients that had BMIs below 30, right? And yet you and I still have to find the words very often to explain to the regulators or explain to our colleagues, does a patient with a body mass index of 27, as was recruited in this study, with established cardiovascular disease, what do we call that patient? Do we say that that patient has the disease of obesity, or do we use the word overweight? And in my view, I think we need to become consistent, because if somebody has an obesity complication, such as cardiovascular disease, you would argue from first principles that they must have the disease of obesity. You cannot have an obesity complication and not have obesity. So that also means that we need to become consistent in the language that we use. And again, we're going to learn much more when the Lancet Commission reports later in January, and many of the people in the audience were part of the Lancet Commission, where we're going to actually find a better definition, or at least more common ground when we talk it. But certainly in my view, a patient that was recruited into the SELECT study did have obesity, because they had an obesity complication, but it also allows us to look at those patients that we know that don't lose as much weight. Because remember, one of the most striking findings that we had in the SELECT, and again the slide was shown earlier, is we only had 10% weight loss in comparison to those patients, who were treated with the step 1 and step 3 studies, where we had 16% weight loss, as was shown yesterday by Arya Sharma. So understanding why it was that these patients lost less weight, one of the arguments could be that if you have a BMI in the lower categories, we know that those patients do lose less weight because, they go back to where they are supposed to be. These medications don't work through mechanical means. It doesn't make people underweight. It brings patients down to the biological adipocyte mass where they are supposed to be. And that also means that these medications are safe when we are using them. So looking at the endpoints that was already been alluded to, it was really this 3-point MACE, the death from cardiovascular causes, non-fatal MI, and non-fatal stroke. And then there was confirmatory endpoints and also then the biological changes. Now, this slide is the money slide, a 20% reduction in the 3-point MACE. But on the side, we also show a 19% reduction in all-cause death, 22% in developing kidney disease, and then also 73% in developing diabetes. All of these are incredibly valuable discussion points when we are speaking to our patients, who do have cardiovascular disease. Because remember, at the moment, the narrative is, because of the supply problems that all of us have suffered, the narrative is that everybody in the world wants to be on these medications. Right? But what we know is that if we look at data that is produced from across the world, maybe 20, maybe 30% of people who have the disease of obesity are prepared to take treatment. So that means that you and I will start to have the conversations with people that says, I don't want to take this medication, doctor. I don't want to take medications for the rest of my life. And then you and I will have to have the conversation about how we're going to actually show the patient the data in a sensible way. And of course, our cardiology colleagues will tell us, we had exactly the same conversations when statins came out. We had to convince people to take statins for the rest of their lives. We had to convince people to take ACE inhibitors for the rest of their lives. Of course, now we are 10, 20, 30 years later, and we think that everybody should be on statins and ACE inhibitors if they have established cardiovascular disease. But we should not underestimate the challenge that we will face to actually convince patients. But this type of data really helps that conversation. This conference was fantastic, and I must say, one of the things I learned from this conference is how to interpret this graph. Until yesterday, I genuinely did not understand this graph, and Donna Ryan was fantastic in explaining that this, what she referred to as the kissing effect of these two graphs, can at least partly be explained by COVID. And the fact that we see with the SELECT study that the COVID deaths were lower in the patients that were taking semaglutide. But COVID happened at exactly that period when the two lines, were connecting. And the argument that's being put forward is that if you were dying from COVID, you couldn't also be dying from a cardiovascular event. Hence, it was a competing deaths effectively. So, and that is a really nice explanation, because I've been puzzled with this graph for some time. And of course, as Donna also explained, because this was the first confirmatory endpoint and with the hierarchical testing, the minute this was negative, they had to stop. Okay? You are not statistically allowed to actually now analyze the data, from that point forward. So that, of course, explains to us what is seen here. Now, that also explains when we look at the cumulative incidence and the composite of heart failure, which was another point. That's why you don't see a p-value there. Okay, so here we see the hazard ratio of 0.82, and you can see the confidence intervals between 0.71 and 0.96, not crossing unity. Okay, but the reason why there wasn't a p-value given was because of the hierarchical testing. So certainly, for myself, I would interpret this as being very supportive of a benefit. And of course, we're going to learn much more about heart failure in subsequent studies. So at least that allows us to understand, with these very complicated trials, but also the rigor that is required. Because if we are overclaiming, if we pretend, that data is there, that can be challenged, we are losing the moral high ground. And I would argue that we have such great data, we do not have to overclaim. We have to understand our data, we have to be able to explain our data, but there's no need to overclaim, because that will in fact just hurt and harm us. So looking at the MACE from the baseline from body weight and also from other anthropometric measures, we can see that, certainly all the groups benefited. Those lines continue to be on the left-hand side, which allows us to say that there isn't a group where we are causing harm. Because remember, the first rule in medicine is do no harm. And what we have shown up to this point is every time we did this type of study, we caused harm, right? So the safety of this study was an important issue that needed to be addressed. Now, this data was another bit of data that I found incredibly interesting and counterintuitive. And this was the data showing, looking at the patients who lost less than 5% of their weight and patients who lost more than 5% of their weight. And what you would see, both of those, the lines don't cross unity, but when we actually run the statistical analysis and compare that, we see that there's no statistical difference between that. Because I genuinely thought that those patients that would lose the most weight would be the patients that have the most benefit. But what we actually see from this line, and if we look at the solid light blue and the dark blue line, those are the patients that were treated with semaglutide that lost less than 5% or more than 5% of their weight. And those lines overlap. Now compare and contrast that to the broken line at the top, which was the line that had patients on the placebo that lost the most weight. Okay? Now, that's a little bit difficult to explain or understand initially as well. So that means if you were given placebo, you were given diet and exercise, as part of the usual care, and you went on to lose a large amount of weight, in fact, you were at the highest risk. And that, again, reminds us that we are dealing here with a patient group that is older and that other things also happen. So much of that could be unintentional weight loss. So that does not mean that diet and exercise is harmful to you. I don't think we should interpret it like that. Okay? But it certainly also does not suggest that if we give diet and exercise, we are going to do an incredible amount of good. Right? So when we're talking about lifestyle treatments, I think we need to come back to this idea that it is not about weight loss, it's about health gain. We want people to have a good diet because of better health. We want people to exercise because of better health. Whether or not they lose weight or not, that's not that relevant, provided they have better health. Because this study suggests that those people that had diet and exercise with placebo and lost the most weight did not, in fact, do better than those patients that did not lose as much weight. So again, important and interesting as we delve into this a little bit more. But let me summarize this slide by saying that the results also suggest that neither change in body weight nor other measured cardiovascular risk factors fully explain the efforts, or the effects rather, of semaglutide. And therefore, we are thinking about specific effects that may be related. Now, of all the slides in the world, this is probably my favorite, okay? This is one of the very few slides where I can actually put this up and say, let's look at serious adverse events of treating older people with this medication. And what you would see on the far left-hand side is that the patients that were treated with an active medication had fewer serious adverse events than those patients treated with placebo. And many of our patients want to know whether or not they're going to be harmed. Yes, they may have cardiovascular benefits, but what other bad things is going to happen to me? And that wonderful talk that we had on cancer that also suggested that we actually see a reduction in pancreatic cancer, new data that's going to be published very soon. That is really reassuring from my point of view. So again, if you do look at the infections and infestations, where we see a reduction, a lower statistically significant difference in the patients treated with semaglutide in comparison to those treated with placebo. So very, very reassuring. That being said, I think we should not underestimate that this medication also comes with adverse events, and we need to be better at managing them. So certainly if we look at the gallbladder-related events, here we see an increase in semaglutide. And again, we are not learning enough from our bariatric surgery colleagues. They have had a treatment that has given 25% weight loss for the last 60 years. We do not need to reinvent the wheel. We need to learn from them and understand how we can also manage those events. Because when we look at the serious adverse events, yes, there are fewer with semaglutide. But look now at the middle box that says discontinuations. So we do actually see an increase in people discontinuing this treatment, semaglutide 16% versus placebo. And this study gave us a lot of flexibility. We did not have to adhere to the very draconian titration schedule where everybody had to be titrated every month. We had flexibility. But I also would suggest to you that we need even more flexibility. And many of you in clinical practice are now telling me, you and like I am, we are titrating these medications much slower. Right? Because there's no value in actually making somebody vomit. Okay? Think a little bit the last time you had vomiting. How much did you enjoy that experience, right? And now we actually think that nausea and vomiting is just part of the cost of doing business with these medications. I don't think it has to be. So I think we have to be gentler, and especially with these patients who are older with established cardiovascular disease, we need to be gentler when it comes to our titration schedules as such. But of course, focusing on the safety on the right, we know about the gallbladder events, but we see that there's no other signal that we are not, there was no unexpected signal here. So very briefly, when we talk about the STEP-HFpEF study that has been presented already, I want to draw attention just to the weight loss. And because this was only a 52-week study, you can see that those curves are still going down. People have not yet plateaued. So actually they are still losing weight, and yet we see a substantial difference when it comes to our quality of life. Now, we have heard a lot in this discussion about loss of muscle mass. And there's no doubt that with all of our treatments, be it bariatric surgery, be it pharmacotherapy, or even with nutritional therapies, if we get enough weight loss, we're going to get muscle mass loss. But ultimately, it's not about the mass of the organ, it's about the function of the organ. So here we've taken older patients, we've made them lose, almost, 10 to 15% body weight. They have lost muscle mass, but what has happened to their function? And when you actually look, over here at the 6-minute walk test, the patients walk further. The patients have better function. The patients come back and they say, I can play with my children or my grandchildren. So what we at least are seeing here is we are not doing harm. And again, I'm coming back to that point. The first rule in medicine is do no harm. We are not harming our patients. Having said that, I think we can do a lot better. And again, learning from our bariatric surgery colleagues, we can actually improve the diet of our patients. For example, pushing proteins first. We can improve the exercise to really protect the muscle, right? But, certainly we are not doing harm when it comes to this. And whether or not we look at the HFpEF patients with or without the diabetes, and when we combine this, we see the benefits. So now what we have seen is that it's being incorporated into our guidelines. And it's when we're actually seeing the most recent guidelines that has been shown previously, now we see that we have, a level 1A evidence when it comes to GLP-1 receptor analogs for cardiovascular benefit. And we also are seeing the same when it comes to those patients with and without diabetes, and especially when it comes to heart failure. And when these evidence gets into clinical guidelines, that's when we're going to be able together to drive the benefit. So let me summarize and suggest to you that these medications cause weight loss, but they also cause substantial health gain, not only measured in the number of events, but also measured in the functionality of our patients, especially those with HFpEF that have reduced functionality. And all of this comes, at a safety level where we are comfortable because we have used these medications for more than 20 years and we are not seeing any safety signals. Thank you very much.
Thank you so much for this impressive talk. Really, really good. So the floor is open for questions, Carl, if you don't mind.
Thank you so much for your nice talk. I wonder what happened to the 80% who did not benefit from semaglutide. 20% reduced the risk of cardiovascular, but what happened to the 80%? Why?
Good question. So again, when we talk about that, and I should have been clearer, we're talking about relative risk reduction. But when we look at absolute risk reduction, so say for example, we have patients, who are at a 20% risk of having an event. What we have done is we've reduced that risk from 20%, by 20%. So that means the absolute risk now goes to 16%. Okay. So again, we need to also be clear that there is still some residual risk. And, I think that is what you are talking about. But what we are seeing, those patients that do have events on the semaglutide arm, of course, it's 20% fewer, but those patients still have substantial improvements when it comes to reduction in developing diabetes, reduction in developing kidney disease, and therefore we see overall that the package is much better. So yes, this drug doesn't take the residual risk to zero, but the residual risk is substantially lower now, in these patients.
I have a question, Carl.
Sure.
So do patients need to stay on this medication lifelong to maintain these benefits? That's number one.
So the question is, do patients have to stay on the medications lifelong? Okay. So with a show of hands, right? I'm giving you a patient that had a cardiovascular event, so he had a heart attack, and you have started the patient on an ACE inhibitor. Okay. Who would stop the ACE inhibitor once you have controlled the hypertension? Raise your hand. Nobody. Okay. Now, you have had a patient with a heart attack, newly diagnosed, and you start the patient on a statin. Okay, you reduce the LDL cholesterol by 50%. Who after 2 years, once you control the dyslipidemia, would stop the statin? Raise your hands. Not too many hands. That is the answer. The answer is that if we think about obesity as a disease, then we will understand that we need to control the disease and keep it under control lifelong. Right? If we think about obesity as something that we just have to help patients control a condition, then you would say get them to the weight and then they can stop. Right? So that is going to be the problem is not starting the drug. The problem is convincing patients that to have this cardiovascular benefit, you have to take this for the rest of your life. And I think that is going to be a major challenge for us.
Thank you so much. The second question, if time's allowed.
There's a question there as well.
Oh, sorry, I didn't see you. The light. Yes, please.
The chairman, you can go ahead and ask. Okay. Very nice study, and we all know about it and the value of this. In your study, you presented that 66% were having prediabetes.
Yes.
How much you think that these people did better than the other group?
Yeah. So I'm not now 100% sure about the prediabetes analysis. So I'll have to come back to you on that. But when we look at the patients with prediabetes, we reduce their risk of developing diabetes by almost 80%. And we know, of course, that prediabetes is a state of higher cardiovascular risk. And very often patients are highly motivated because they have seen their family members developing diabetes and actually being able to say to them, we are not only going to stop you developing diabetes, I'm going to turn the clock back and make you normoglycemic. That's very, very motivating to the patients to also understand the benefits. But again, that only materializes with long-term treatment.
Yeah, I think my point, as you probably expected, is that people without prediabetes might do it different than people with prediabetes. And I think this needs to be analyzed. Thank you.
Thank you so much, Carl. That's very impressive. Thank you.